So Alejandra, I think we have to start.
Yes,
It's one.
we have to start. John is going to present the,
Okay.
do you want me to start, John, or?
John is connecting.
Okay.
So we're going to do this, and then the business meeting is immediately after this. Is that correct?
Okay, so I think I will
Yeah,
start. I will
yeah.
start because John is having troubles with the connection.
Okay.
So, greetings to all colleagues, both panelists and attendees of this webinar. It is an honor to welcome you to Ground Round number 10, the final session of this year's series. This marks the conclusion of a successful cycle of events in 2024, where we explore significant topics in uveitis each month through clinical case presentations. Looking ahead to 2025, we will commence the new series on Saturday, January 11, with the topic of COVID-19 and ocular inflammatory involvement. Today, we are privileged to have an outstanding panel to discuss acute retinal necrosis. Dr. Bodaghi will deliver our thematic lecture from France. A presentation of Dr. Sofia Androdi and Dr. Athanasios Papas from Greece will follow this. Next, Dr. Fernando Arevalo and Dr. Jacob Heng from the US will present their case. Finally, Dr. Karsten Heinz and Dr. Charlotte Wattman from Germany will conclude the session with their contributions. Dr. Bodaghi will start the session.
Good afternoon. I would like first to thank the International Uveitis Study Group for giving me the opportunity to talk on acute retinal necrosis syndrome. And I have no financial interest in this talk. And I would like to especially look at the management of this entity with you. This is obviously a major infectious condition with one of the absolute emergencies in the practice of uveitis, with a prompt diagnosis and therapy mandatory, high rate of complications, unfortunately, and a poor visual outcome. If we look at the viral agents, you have the list here of the herpes viruses, but we have also other viruses responsible of necrotizing herpetic retinopathies. But for acute retinal necrosis syndrome, we have mainly HSV1 and 2 and VZV involved. And if we look at the spectrum of the disease, of the herpetic eye diseases, of course, we have keratitis, the group of keratitis, the group of anterior uveitis, and among retinopathies, we have those which are major part of it, the necrotizing part of these herpetic retinopathies, the acute retinal necrosis syndrome, either peripheral or multifocal posterior at the posterior pole. We have the progressive autoretinal necrosis syndrome and the CMV retinitis, and a very limited proportion of patients with non-necrotizing herpetic retinopathies. The disease was first described in 1971 as Kirizawa's uveitis by our Japanese colleagues as an acute uveitis with retinal obliterative vasculitis, confluent yellow-white lesions at the retinal periphery. And this is just a recent review on the disease, diagnostic and therapeutic challenges in eye. And if you see, they have just summarized here the three classifications, one in 94 by the American Uveitis Society, the other one more recently by the Japanese ARN study group in 2015, which was validated and introduced for the first time the PCR analysis of the aqueous humor and intraocular fluids, and eventually in 2021, the SUN classification for ARN for the clinical trials and ARN, which is also important. Again, what is important is to look at the anterior segment where you can have very typical KPs. And when you look at the fundus you will find these yellow lesions at the periphery with retinal vasculitis, obliterations, and occlusion of the arteries, as you may see beautifully here, which may give you at the end, unfortunately, the poor visual outcome. These are a few other presentations, again, at the periphery with the vascular occlusion, with hemorrhage. Sometimes you may have very small foci of retinal necrosis with hemorrhage. They will coalesce and give you at the end these larger areas of retinal necrosis. And again, you may have papillitis, arteritis, such as here as Curialis variants of arteritis with acute retinal necrosis. This patient was referred for a Behçet's disease, but it was an acute retinal necrosis syndrome. Again, another case in a child of HSV-2 infection at the level of the superior temporal vessels with vasculitis before and fortunately after an aggressive antiviral therapy. The diagnosis is made by mainly by PCR applied to the aqueous humor, real-time PCR for its rapidity, high sensitivity, and quantification. And it's also important to use, many of us are now using the PCR applied to aqueous humor in patients under therapy in order to see the decrease of the viral load. This is a paper published in 2017 on the characteristics and clinical outcomes cohort of PCR positive patients. And if you look at the visual acuity, you see that about half of these patients in this series of 36 patients and 41 eyes, about half of the eyes had a poor visual outcome or a low visual outcome, and the retinal detachment was very frequent, about 24 eyes out of 41, and a second retinal detachment in 6 eyes, recurrence of retinitis in 5 cases. The other variant is rapidly progressive autoretinal necrosis syndrome described in 1990 in immunosuppressed patients, full thickness retinal necrosis in the posterior pole, the mid-retina, and the peripheral retina. It's a very rapid condition involving both eyes in 71% of cases. You have very minimal vitritis compared to ARN and the non-granulomatous mild anterior uveitis. Unfortunately, the visual prognosis is guarded in these patients with a high rate of blindness. And at the end, the CMV retinitis, which is the third type of herpetic retinitis, when you see these areas of peripheral retinitis associated with vasculitis at referral and or after specific anti-CMV therapy, as you may see here with healing. We have also very rare cases after the orchestrain live zoster vaccine with, in this case, the whole genome sequencing, confirming the ocular strain derived from the vaccine without new mutations or recombinations. What is the treatment? It's obviously an emergency, and this is our protocol. We use an induction therapy with antiviral agents, mainly acyclovir in non-severe cases, 10 milligram kg every 8 hours, IV foscarnet, 90 milligram per kg every 12 hours, in a few days, going to 2 weeks, and then maintenance therapy with oral valacyclovir, 3 grams per day, especially in immunocompetent patients. And we associate them with intravitreal injections of ganciclovir or foscarnet. What is the duration of treatment? It's very variable, going from 3 months to many years. And for some people, they don't stop therapy. Discontinuation may be a factor of recurrence, especially in those who have already lost one eye. Use of steroids remains controversial. Only after initiation of antiviral treatment, only oral prednisone, and you have to see the dosage. I'm not for local injections of steroids or for IV pulses. Never use immunosuppressive agents in these cases. Aspirin may be used. Laser photocoagulation is controversial. and so the prophylactic vitrectomy. The management has been studied by our Japanese colleagues and published in 2022 in Ocular Immunology and Inflammation, as you may see here. Intravitreal injection of antiviral agents was not performed in 140 cases. Intravenous drip infusion of antiviral agents in many of them, so antiviral therapy was done. And systemic corticosteroids was used also in 140 patients, which means 94% of the cohort. And you see that unfortunately, regarding the based on and despite the treatment, you have a poor visual prognosis at 6 months, 1 year, and 2 years. And this is really an issue in our patients, even when you treat them well and aggressively. What are the risk factors for retinal detachment in acute retinal necrosis syndrome? Acuity at presentation may be a factor, and clock hours, the number of clock hours of retinitis. These are the two risk factors associated with the rate of high rate of retinal detachment. And what is the surgical outcomes of these retinal detachments cases in a cohort of PCR positive patients? You have here the total eyes, 34 of 34 patients. Vitrectomy was performed with the scleral buckle in 41% of the cases. The extent of retinal detachment, macula detached, unfortunately, in 61% of cases, and PV on 20 in 67% of cases. The recurrent RD in 36%, and time to recurrence was 8 weeks. Single surgery anatomic success was 63%. Silicone oil was used in majority of patients and removed in 30% of cases. Cataract surgery in 72%, and recurrence of, and you see the final visual acuity, unfortunately, is low. This is the descriptive of visual acuity outcomes at 1 year after retinal detachment repair. Again, and you see that depending on the zone involved and this posterior pole, of course, you have a poor visual prognosis. What we have done was to see with our group the clinical and biological characteristic and prognostic factors in a cohort of patients with CMV retinitis, but also with HSV2 and VZV, a total of 37 patients. This was just to follow the viral load of the patients by performing PCR after during each injection, intravitreal injection. And as you may see, we had the two profiles, the rapid responders and the slow responders. For those who are slow responders, the viral load remains very high during weeks of therapy. And this is just the evolution of visual acuity according to each virus for CMV, HSV, and VZV. And you see that the poor prognosis is associated with a VZV, more with a VZV infection than an HSV infection. These are the factors associated with the occurrence of retinal detachment in our series. Age was one of them. And also the baseline BCVA, the low visual acuity at referral, was a risk factor because inflammation and infection were more important, and also the number of intravitreal injections, which may be related to the severity of each case. This is the comparison between treatment on oral valacyclovir versus intravenous acyclovir, and in this group there are not so many difference between the two groups. This is why many colleagues are proposing oral valacyclovir for the treatment of patients with ARN. I think that this is really depending on the severity of the disease, and if you propose oral therapy, you need to associate intravitreal injections of antivirals. The necessity and optimal time for performing pars-plana vitrectomy was also studied, and in this study, prophylactic PPV showed no difference in recurrent RD rates, and the authors are not recommending prophylactic vitrectomy to prevent retinal detachment, nor to improve the prognosis of acute retinal necrosis based on the research. A very nice review by Rupesh Agrawal and many colleagues on antiviral treatment, systematic review and meta-analysis, showing the rate of retinal detachment in studies, cataract, optic atrophy, epiretinal membrane, and uveitic macular edema, and eventually glaucoma. And this shows, of course, that complications are very frequent in these patients. A common practice patterns in the diagnosis and management of acute retinal necrosis. This is a survey by the American Uveitis Society with you see here those who have responded and filled the survey. This is just the number of intravitreal antiviral therapy in immunocompetent patients. Likelihood of intravitreal injections. You see that many of our colleagues are proposing injections if it's bilateral, and 40% if it's unilateral. It's always frequently, so the majority is injecting. If it's unilateral, one at initial presentation, some of them weekly and every 2 to 3 days. And if it's bilateral, of course, injection is performed more frequently. This is just the duration of systemic antiviral maintenance dosing. As we discussed previously, it's proposed indefinitely for 58% of them, which I think is very close to what we have in real life all over the world. The frequency of systemic versus local corticosteroids. We see that systemic corticosteroids are proposed by many of us. I think that, again, we should be very careful and not propose it too rapidly in order to have a control of the viral replication. This is the frequency of vitrectomy, and we see that depending on the training and non-retina or retina, you see that many of our colleagues are not, the majority are not proposing, and I'm very happy to see that vitrectomy, because it's not the right solution to avoid retinal detachment. The best solution is to treat aggressively the viral infection. Macular edema may be an issue, and this is something coming up, and it's a paper from India in ocular immunology and inflammation, and showing a good response and a good resolution on topical bromfenac, but also the use of topical interferon therapy, which may be interesting in these cases. Again, I'm not very used to intravitreal injections of corticosteroids in patients with acute retinal necrosis syndrome. To summarize, I would say that this is an absolute emergency. It's a sight-threatening disease despite appropriate therapy, and depending on the host immune status. Different entities with similar clinical presentations, and you have to diagnose and especially to have your virological diagnostic confirmation, because the VZV has a prognosis which is more severe than HSV. Therapeutic approach adapted to the severity of each case and initiated without delay. And the best way to avoid retinal detachment and further visual alterations, of course, the aggressive therapy you will perform, you will initiate, and not the vitrectomy by itself. With this, I would like to acknowledge all my co-workers in Paris, Pitié-Salpêtrière, Sorbonne University, and I would like to invite you next year to Rio de Janeiro, June 25 to 28 for the the 18th meeting of the International Ocular Inflammation Society. Thank you very much.
Great. Now, Sophia, or
So Thanos is presenting. We are very
Okay.
glad to
Me.
be here. Welcome to this IUSG session from our end. And Thanos will start. He's my fellow and will start to present a typical acute retinal necrosis case.
thank you, Sophia.
Hello, everyone.
Hi.
Let me just. So, dear esteemed panel, it is my honor and pleasure to present you a typical case of acute retinal necrosis. My name is Athanasios Papas, and I am a fellow of Professor Androudi. So our case entails a 32-year-old male who comes in complaining of blurred vision and floaters for the last couple of days. His past medical history was non-contributory, and he was a mild myope. These are the color photos of the optic nerve showing edema in the right eye and peripheral Uveitis infiltrates. And these are the fluorescein angiographies
Sir, your
showing vascular
slides are not
congestion
visible. Your slides are not shared, right?
at the optic nerve, hypofluorescence around the optic nerve, most probably because of subretinal fluid, and peripheral vasculitis. The OCT confirmed the existence of peripapillary fluid, along with raised pockets of peripheral fluid. We thought that this was a typical case of acute retinal necrosis in day 0, so the patient was hospitalized and started on intravenous antivirals 10 milligrams per kilogram 3 times daily for 2 weeks. And 3 days later, he was also started on oral prednisone 1 milligram per kilogram. A full uveitis workup and imaging was negative, except for the presence of retroperitoneal fluid, for which the infectious disease specialist could not give us a reasonable explanation. An anterior chamber tap came back positive for varicella zoster virus. And 2 weeks after, the patient was started on oral valacyclovir 1 gram 3 times daily, and then once daily, along with slow tapering of the oral prednisone over 3 months. The fundus picture started to improve slowly, and the optic nerve edema started to resolve gradually along with the peripapillary fluid. And a couple of months later, the recovery was full. However, the severity of the situation was explained to the patient, who agreed to our suggestion to continue with the oral antiviral therapy. But, despite the antiviral treatment, a subtle macular edema with a trace epiretinal membrane started to appear. And this is the angiogram of the affected eye, showing a still hot disc and subtle feathery vasculitis and macular edema. And the situation persisted, despite antivirals. To the left, you can appreciate the subtle macular edema, while to the right, you can see the healed lesion of the retinal necrosis. Unfortunately, wide field imaging was not available back then. And over the time, situation got even worse, so we decided to add some oral steroids and a dexamethasone implant. And during the follow-up, we also performed the cataract surgery, and the patient also underwent a vitrectomy to the same eye for retinal detachment with gas and anatomic reattachment. Over the years, the patient was still on 1 gram daily of antiviral therapy with a visual acuity of 20 to 30. And 8 years after the first incidence, still on oral antivirals, Maxidex and bromfenac eye drops daily. However, 11 years after the first event, everything was discontinued, with a dramatic worsening of his macular edema and drop in visual acuity to 20 to 40. And this is his most recent OCT, where you can see extensive cystic changes in the macular area with 20 to 40 visual acuity. The patient is still off oral antivirals, but he continues to take bromfenac PRN with no improvement whatsoever, as you can see. You just heard the beautiful lecture from Professor Bodagi, so I'm not going to go deeper into more details about the clinical picture of acute retinal necrosis, but I want to highlight again that acute retinal necrosis is a peripheral necrosis with rapid progression and circumferential spread without treatment. There is a dense vitritis and occlusive arterioral vasculopathy, as you can see in the picture to your right, that was referred to us for central retinal artery occlusion. I also want to point out that diagnosis is clinical, and you can confirm it with either an anterior chamber or vitreous tap. Differences in sensitivity or specificity are really not statistically significant according to the literature, but anterior chamber tap is probably safer and less invasive. Indeed, in a retrospective case series by Sims and Associates, where 14 patients underwent either anterior chamber or vitreous tap or both, retinal detachment rates were 60% after vitreous tap, but only 30% after anterior chamber tap. However, in this series, no statistical significance was found. How long do we give antivirals? This is the million-dollar question. Bilateral disease has been reported in up to 75% of untreated cases, even after more than 40 years. This, of course, goes down to 13% if the patient gets antivirals in the acute phase. And complications occur, mainly retinal detachment, in up to 75% of the cases. These patients need surgery, but the results are not always favorable, as recurrence rates are high. Cystoid macular edema, another dreadful complication, is not always easy to treat and can be very persistent. There are three main treatment approaches: oral antivirals alone, intravenous antivirals alone, and both systemic and intravitreal antivirals. The literature suggests that there is a trend towards better visual acuity improvement and recurrence rates in the combined treatment approach, although this does not reach statistically significant difference. Cystoid macular edema in acute retinal necrosis cases is the result of the breakdown of the blood-ocular barrier. And indeed, our patient had evidence of band keratopathy years after the first insult. There is no established therapeutic approach for these cases, but literature reports improvement with dexamethasone implants, interferon, aflibercept, and tocilizumab. A small case series of 7 patients showed central macular thickness decrease right from the first week of treatment that relapsed after cessation of interferon. And in our case, cystoid macular edema was stable, but relapsed after discontinuation of antiviral therapy. Thank you very much for your attention, and I'm more than happy to take any questions.
Thank you, Thanos, for your beautiful lecture. This is a case of almost 14 years of follow-up. He was a young patient that was diagnosed and treated in day 0. Everything were as per protocol, but despite that, some months later, he started to develop CME. The situation was explained in terms of the duration of antiviral treatment because he was also very frightened of the virus getting to the other eye. So he agreed to keep the antivirals for quite a long time. It was 10 years or more on antivirals. But the situation with CME was totally different. It was because of the low-grade inflammation, despite the PCR coming back negative, after the treatment. And this is the usual thing with the acute retinal necrosis-related macular edema, because there is some evidence of slow, low-grade inflammation, because we often see cells in the anterior chamber, and this is already reported in the literature. And this is why our patient had also band keratopathy. Also, there are, we didn't do that, but there are reported elevated cytokines, IL-6 and IL-8, IL-6 and IL-8 in patients with acute retinal necrosis, macular edema. And to my experience, this is very, very difficult to treat. We gave the patient intravitreal the dexamethasone implant, and he came back with a retinal detachment that was fixed, luckily with air, because it was a superior retinal detachment. He had a trace epiretinal membrane, and this is quite usual in these cases, but with no traction. And there is some characteristic in the OCT, mainly that this edema had intraretinal fluid and hyper-reflective foci, which is because of the microglia activation because of the inflammation. So I would like to hear your thoughts on treating The macular edema, in these cases, we didn't give any interferon, we didn't give any tocilizumab, but our patient was happy with the bromfenac and the antivirals. But as soon as we stopped the antivirals, you see how the edema went, and the patient kept getting his bromfenac and steroid drops. But you see that the cystic changes got worse. And I don't know if you have any experience or any cases, or you see that often. What do you think?
So maybe maybe I can mention there are many ways to skin a cat, but I like to use intravitreal dexamethasone implant, and I agree with that option. But it's very important that we continue covering with antivirals to avoid any recurrence. So that's what I do. I keep them on antivirals, but I give intravitreal dexamethasone implant, and it seems to work. But patients may need several implants over the years.
So
It is
Fernando,
reported in the... sorry, Visali. Hi, Visali.
there is a question in Q&A. Both of you mentioned giving a long-term antiviral. So it's being asked that after 3 months, what dosage you will give and for how long? And I think that's very important. If we are injecting Dex, would you increase the dose at that time, or would you continue low dose? Like, I think all of us might have different protocols. So Megan can probably ask each one because it's a very important issue.
I keep low dose prophylactic doses. I don't increase the dose.
What is that dose? That is what the question is.
So it would be 900 milligrams once a day.
Yes, Megan, you can take over. Sorry for.
Oh, that's okay. I didn't want to step on anyone's toes. Dr. Andruti, what would you do? Would you use 1 gram of Valtrex as a prophylactic dose, or would you go up to say 1 gram 3 times a day if you were using valcyclovir?
Using 1 gram daily, but if for some reason I would expect a relapse, giving a dexamethasone implant, although it's not reported in the literature, for the peace of my heart, I might increase the dose, but generally I would agree with Fernando that I don't increase the dose.
How about you, Dr. Hines?
Okay, thanks. Yes, so we will look carefully if there's any change. So we will keep them on 1 gram usually. So trying to answer our experience with bromfenac with NSAIDs. So this is something we are not going to use regularly. So usually we start first with intravitreal steroids, as Fernando also mentioned. And if we notice that it needs to be done in a very, very timely, close manner, so three times a year or so, we will swap on to the fluoroquinolone acetonide to have a long-lasting effect. And then when we have the long-lasting thing in the eye, we keep them on the antiviral for a long time.
There is an excellent paper in ocular immunology on treatment of macular edema in acute retinal necrosis. And it reports on bromfenac, and this is what we did in our patient. And it also, the authors report that there is no relapse usually after giving intraocular dexamethasone implant. The only thing is that you have to be very careful, because when you give that, it exerts traction in the vitreous base. And this is why you might have a retinal detachment, because they have atrophy in the periphery. So it's much more frequent. I think in their case, it was around 50 or 60% retinal detachment after a dexamethasone implant. You have to be very careful. And this is what happened to our patient also.
So if it's working with the NSAID alone, it's quite nice, because these are only drops. Sure.
Anyone on the panel have any experience with difluprednate, trade name Durezol in the United States, for the use of treatment of the CME?
I don't.
It's
Very
not available.
limited.
We have
The ER. Yeah.
we have tried it, but I'm not very impressed with the results.
I agree. I just
Has anybody
talking about
tried
topical therapies.
topical interferons? We have a paper from India, Bangalore, about topical interferon therapy for cystoid macular edema. I personally have not tried, but anybody has any experience? Okay,
No,
nobody. Perfect.
nobody.
If I may, excuse me. Can you hear me?
Yes.
Hello.
Hi,
I
Grandpa.
think, hello, how are you? I'm sorry. I think that I cited the paper in my talk. I think it's very interesting. What we used to treat, how to treat these patients was using systemic interferon. And as systemic interferon is no more available, the two options are topical, but it's difficult for us to obtain it. It depends in the geographic areas, but I think that is for sure a good solution. The other way will be tocilizumab. So these are the two options that we can use.
Systemic, no?
Yeah.
Yes, systemic.
There is a question which, has anybody ever tried intravitreal acyclovir? I don't know, I've never tried.
No, because the biodisponibility of acyclovir is usually good. So I think that systemic therapy is okay. And the fact that in severe cases, acyclovir is not really the most efficient, and we go for foscarnet or ganciclovir gives this possibility for local injections of those drugs and not acyclovir.
All right, should we move on?
I believe the next case is my fellow, Jacob Hang. Jacob is a fantastic second year with a retina fellow at Johns Hopkins Wilmer Eye Institute. He's so good that we're interviewing him, and he's actually on Monday giving a lecture to be hopefully one of our faculty. So Jacob, take it away.
Thank you, Dr. Ravelo. Hi, can everybody hear me?
Yes.
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 All right. Hi, I'm Jacob. So today, I have no financial disclosures first of all, but we're going to discuss a clinical presentation of a what we'll consider a somewhat complex case of ARN, and then we'll review some limited relevant literature and management of this patient. So the story here is that we have a 57-year-old female patient with a history of kidney transplant who was referred by an outside retinal specialist with concern for ARN. So she had this long simmering course of shingles in outside of Johns Hopkins. So 2.5 months before coming to us, she had shingles involving the left V1 distribution, which resolved with 10 days of Valtrex 1 gram daily. And then half a month, like maybe 2 weeks later, the shingles recurred, and now it involves the tip of her nose. And so there was concern for eye involvement. She was seen by an optometrist. The findings were not really documented at this time, but she was restarted on the Valtrex 1 gram daily, and then referred to a retinal specialist outside of our institution. Another 2 weeks later, it was noted that she started to have anterior chambered cell and pseudodendrites. So they started Pret Forte while continuing the Valtrex. And then another 2 weeks later, it was noticed that the anterior chambered cell resolved, and now the Valtrex was reduced to 500 milligrams daily. So about 3 weeks passed. This time around, it was noted that the pseudodendrites resolved. They have put her on ganciclovir. She's still on that very small dose of Valtrex daily. But a day before coming to us, she went back to the retinal specialist who saw her initially for new floaters in the left eye. And this time he noted ARN with retinal detachment. So in the past medical history, we mentioned that she does have a deceased donor kidney transplant for focal glomerulosclerosis, secondary to preeclampsia when she was young, when she had her second child. She's also colonized with C. difficile. There's no relevant ocular history besides what we just talked about on the first slide. And she's on mycophenolate 1,000 milligrams BID and tacrolimus 2 milligrams BID for her kidney transplant. She's allergic to penicillin and codeine. There's no relevant family or social history in this case. So coming to a functional exam, so she's 20/25 minus in her right eye, pretty good vision. And then 20/70 in the left eye with correction and pinhole to 20/60. Notably, there is an APD in the left eye. Intraocular pressures are normal. There's some restriction of the nasal visual field in the left eye, otherwise full confrontation visual field in the right eye and full extraocular movements. In terms of her anterior exam, so starting with the left eye, notably there's some injection of the conjunctiva. There are correcting precipitates and some subepithelial opacities in the cornea. There's 8 anterior chamber cell and flare, 2+ cell and 1+ flare. There's some iris transillumination defects. There's a very mild nuclear sclerosis cataract, and the anterior vitreous is significant for 2+ cell with haze. The examination of the anterior exam of the right eye is basically normal. This is just the fundus, color fundus photo, white field color fundus photo of the right eye, which is essentially within normal limits. You can see there's maybe a small choroidal nevus in the inferior arcade, but otherwise there's no notable inflammation or vasculitis in this photo. And this is the white field color fundus photo of the left eye. So the attention is immediately drawn to the periphery where there is significant retinal whitening. But more importantly, if you look at the temporal periphery here, area to the retinal whitening, there's very, very thin and detached retina. And I'm just going to scroll through this, but there is so this is a better superior view of the extent of that retinal detachment. So it extends basically almost 360 degrees. And inferiorly, it's hard to see, but there's detached retina as well. That's not as well captured on this photo. This is the OCT of the macula of the right eye. There is some outer retinal change, but otherwise this is normal and stable, and we have seen it on serial OCTs, and it hasn't changed. And then in terms of the OCT macula of the left eye, as we're talking about macular edema in Arndt, she definitely has some traces of macular edema in the nasal macula. I'm just going to scroll back here to the slides where this is most obvious. But notably, if you look at the infrared image, there's probably some very mild optic disc swelling as well. This may be not as well appreciated on the color fundus photo. So at this point, I just want to pause and talk about some relevant discussion points in this case. So we talked a lot about medical therapy in Arndt. I think that's probably the cornerstone of management in Arndt patients. There's some limited evidence to show that intravitreal foscarnet in combination of systemic therapy can reduce risk of retinal detachment by up to 67%. It's also notable that if you don't treat these patients with systemic therapy, the risk of contralateral eye involvement is up to 65% at 2 years, which can be reduced to 25% with appropriate antiviral therapy. We commonly use topical steroids, and systemic steroids are a lot more controversial. Certainly, as we've already discussed on this panel, we do not want to start systemic corticosteroids before initiation of antiviral therapy. And then in terms of the acyclovir and Valtrex dosing in Arndt, so the standard of care for dosing is really based on the IC50 for VZV. And this has to be done for at least 7 to 10 days. The standard dose that people talk about is IV acyclovir 10 milligrams per kilogram for every 8 hours. this translates roughly to 2 grams TID of Valtrex that we commonly use. The reason we use 2 gram TID and not 1 gram TID is because in sort of pharmacology studies that you need at least 1.5 grams of Valtrex every 8 hours to achieve the IC50 for VZV. So one gram would be underdosing in ARN. So, and following this initial course of 7 to 10 days, there's again some recommendation for maintenance course of 14 weeks of PO acyclovir at 800 milligrams 5 times a day because of the greatest risk of fellow eye involvement during this time, which translates to about Valtrex 1 gram 3 times a day. And then coming back to our patient, so her creatinine clearance, which is estimated by her eGFR based on her serum creatinine, is 37. So if you look at this chart, she really needed 2 gram BID, 2 gram 2 times a day of Valtrex when she developed, not even just ARN, but when she developed zoster. So she arguably was underdosed on her initial presentation. There are some, obviously, there's some possible dose-dependent adverse effects that we are always wary of. So nephrotoxicity, neurotoxicity, and Haas TTP, those are the main ones. And then last couple of things to discuss. So the first is the role of laser retinopexy in ARN. So some studies have shown decreased risk, no reduction in risk, or increased risk of RD following prophylactic laser in ARN. There's really no randomized studies to date. Some of these studies are probably prone to selection bias. So as such, I don't think there's really clear evidence to recommend prophylactic laser retinopexy, although it would make sense in certain cases. The other thing to note is that some of these cases some of these eyes are really inflamed and also has significant vitritis. So it may actually be hard to see and hard to laser, not just for the provider, but also for the patient. And you can definitely cause iatrogenic breaks over necrotic retina. And the last thing that I think has already been discussed here is there's no evidence of benefit for prophylactic vitrectomy in non-detached ARN. And then there are no studies on the timing of surgery for retinal detachment in the acute hepatic phase of ARN, but delay in surgery is often favored until retinitis is controlled. These patients have a very high redetachment rate of up to 58% after initial vitrectomy. And for this reason, a lot of surgeons favor silicone oil over gas. Again, not based on any randomized controlled trials. So this is more a rhetorical question at this point, but what would you do? We could discuss this more.
I don't know if Jacob, can stop here and ask the panel,
Okay.
maybe if they can comment. We have a macular on retinal detachment that is an emergency, but the acute retinal necrosis is active. And I would like to know what the panel would do in a case like this in terms of treating before doing the retina detachment surgery, or the retina detachment is more important and you would do the surgery as an emergency today. How do you manage it? Whoever wants to make a comment. We don't have a lot of time.
Thank you, Fernando. If I may, I don't see if others want to comment, but this is a great case presented by Dr. Heng. I think that in this case, I would go for surgery for sure, but we have 2 or 3 days. So I will start with aggressive antiviral therapy. For the intravitreal injections, you need to be very careful because you have the detachment. So that's another issue. But I would for sure not delay too much surgery. Of course, the systemic antivirals are there and very aggressively. No corticosteroids, of course, at the beginning in order to go for surgery. And then the surgical procedure is a little bit complicated, but very complete with probably silicone oil at the end. So that would be my management.
Anybody feels differently?
No.
Because we need to go on. Yes, Vishali.
But Fernando, I don't know what has happened in the recent past. I see patients with acute retinitis and retinal detachment. It's no longer that they heal and then they develop detachment. So I have done a couple of surgeries with acute fulminant retinitis. Like Bahram said, very aggressive, 48 hours of treatment. It works very well. I have had good outcomes. Only thing is the hyaloid you can separate only till the mid periphery. And then you got to leave it because it's so sticky in the periphery that you can't really go all the way out. But that's the only thing. But a great case. A very
That is
challenging.
correct. Well, we're not finished. Let's see, Jacob, let's continue because we have limited time.
Okay. So we'll talk about what we did. So thank you for Dr. Badagi and Dr. Gupta for your comments. So we did intravitreal Foscarnet. We started like a twice weekly regimen, and we did admit her to the medicine service with nephrology and infectious disease on board. She was started on aggressive IV acyclovir, 10 milligrams per kilogram every 8 hours for 14 days with careful monitoring of renal function. We deferred surgery or laser for 5 days while this was going on, and also monitoring her retina very closely by the retina fellow. So actually, I was the main person that was examining her every day. So eventually, we did bring her to surgery, and I'm just trying to advance my slide here.
Still with the macula, unfortunately.
Yes. So at this point, those 5 days out, and her macula is still attached. So this is we used at Wilma we use a 23 gauge. For this case, we use a 23 gauge Duroc EVOS system. Very careful placement of the trocars here because she's still phakic and has very, very little cataract. And also a 25 gauge cannula was placed for chandelier light for illumination here, anticipating that the view may be a little difficult. And so we start off with a very careful core vitrectomy and moving to the periphery to make sure that we remove vitreous, and also at this point taking some opportunity to debride some of that detached necrotic retina without pulling too much on the rest of the retina. Here we inject perfluorocarbon heavy fluid to weigh down the macula and protect the macula. And now we do more careful peripheral shaving. Again, trying to remove as much
Let me make a
vitreous as
comment, and
possible.
Jacob, when we inject perfluorocarbon, what I like to do also to Vishali's comment is that perfluorocarbon viscodissects the peripheral vitreous to the periphery, and then the shaving can be done more safely and complete.
Yes, I totally agree, Fernando. And recently I used 20,000 hyperwit cutter. It works really well because you can go very close to the retinitis lesion and shave the vitreous off. But I totally agree with you, PFCL helps.
Nice.
So
Silicone oil. Yeah. Go ahead, Jacob.
Oh, sorry. So to finish up the surgery, as you can see, we did laser, did fluid exchange, and still silicone oil, and injected Foscarnet at the end, and some subconch injections. So just going to skip ahead. So this was day one. The photo on the left shows day one of surgery. She is under oil. There's a small bubble inferiorly. There's the Foscarnet, and she's attached, and there's no evidence of retinal whitening posterior to the laser barricade. And she is actually 21, 25 on pinhole in terms of visual acuity. And this remained the same at 3 weeks post-op. And now you can see that the laser scars have more or less healed. And again, no evidence of whitening posterior to the laser barricade. And this is going back to this is a fluorescein angiogram at post-op week 3, again showing there's no active vasculitis, there's no notable inflammation just posterior to the laser barricade here. And this is the OCT of the macula in the left eye under silicone oil. Notably, we don't see any evidence of macular edema at this point. And then in terms of a clinical course, so she had a pretty, I would say, a pretty complicated post-operative course here. So 6 months after her vitrectomy, she underwent silicone oil removal and cataract surgery, and everything being stable then with no recurrence of retinitis, and she achieved a best corrected visual acuity of 2200 at that point. However, 6 weeks after silicone oil removal, she developed a total tractional retinal detachment, and her vision had dropped to light perception only. She underwent a repeat vitrectomy with silicone oil for retinal detachment repair, and also received 6 doses of post-op weekly intravitreal methotrexate because of the proliferative vitreoretinopathy, the PVR. But despite this, she developed progressive supranasal traction, and she lived really far away. And at this point, she was she really didn't want any further intervention, knowing that her vision is probably not going to be much better than this. So she elected for observation, and this traction actually was more of a traction localized detachment, has remained stable under silicone oil, and she's hand motions in the left eye. So this is the final slide. The photo on the left just showing the total retinal detachment 6 weeks after silicone oil removal with vision of light perception only, and the photo on the right showing the post-op photo 4 months after the second vitrectomy, where the supranasal retina has very significant traction and actually some shallow detachment as well, and this has remained stable to this day. So thank you very much for listening. I want to thank all these other excellent doctors for taking care of this patient as well.
Thank you, Jacob. Super presentation. Our time's up, so I just want to make a couple of quick comments. So for PVR, we're using intravitreal methotrexate to avoid the recurrence. In this particular patient, didn't work that well, but we use 400 micrograms in the silicone bubble at the time of surgery, and then every week for 8 weeks. And it seems to work very well on our patients. So most of the patients did avoid the recurrence of PVR and redetachments. Regarding the use of a buccal, Baran mentioned the Vascular Pulmonary Eye Institute, where they used 40% buccal in their cases, but they had 60% of PVR. I don't add a buccal really on my arm cases unless they have peripheral PVR. And if I'm going to keep the peripheral retina, most of the time it's not necessary. I don't know if in that series steroids was not used. It's controversial, but I feel that using steroids after you start antivirals can decrease the inflammatory process and decrease the chances of developing TRD. In terms of prophylactic vitrectomy, I know it's very controversial. Baran very eloquently mentioned that the systemic treatment very aggressively is the best treatment to go. And I agree with that. But I have had cases where prophylactic vitrectomy has been helpful if there is no good response, it's a fellow eye, the lesions are close to the fovea, and I want to stop it. And the active lesions resolve quickly. Studies have shown the inflammatory cytokines in the vitreous of patients with ARN. I think that if you reduce those inflammatory cytokines with a vitrectomy, you have a good chance of helping. Miseroki and Wataru in Retinal recently presented cases of prophylactic vitrectomy with pretty impressive results. And I think that that's something that should be revisited on selected cases. Those are my comments, and sorry we went over time. Thank you.
If
Can
I
I
may
make
comment, Fernando, prophylactic vitrectomy, as a surgeon, when you are seeing, I'm itching to go in and remove everything, especially when PVD occurs and everything comes anteriorly. But sometimes you have to control yourself not to go in. But, if the panel thinks prophylactic vitrectomy is recommended, I would love to do it for all my patients.
I don't think so. I don't think so.
Okay.
I think the panel is not in agreement completely. It's going to be controversial always. Yeah. Maybe we can put our cases together and see what happens, see what we find.
Let's do.
Yeah.
Wanted
Should
to
we?
just make one comment. In CNV retinitis, we saw that active retinitis was associated with like a threefold higher risk of retinal detachment, and I don't think that we're have data on that for ARM, but it's probably something similar. And so, getting the active retinitis under control as fast as possible is a good idea, and this is probably, you know, the rationale behind intravitreous injections.
Completely agree, John. Definitely.
Okay, should we go on to the next case? Yes. So as we all noticed, it's quite a challenge to treat the patient, as we have seen in the last case. And so we are, Charlotte and me, we're very happy that we have the opportunity to present our case. And to be honest, we don't know what we treated and what we have seen. So we got an answer in the end, but we still thinking, is it also acute retinal necrosis? And so Charlotte is one of our fellow in our office in Münster, and she took over that lady, which was seen this year, and she will present the case of something which looks like retinal necrosis. Charlotte.
Yeah, thank you very much. I'm going to present the case of an 81-year-old woman that initially came to our consultation with a referral from her local ophthalmologist because of a vitreous hemorrhage. She complained about a unilateral vision impairment on the left eye for the last 6 weeks, which worsened 1 week ago. The ophthalmological history only included a cataract operation on both eyes 4 years ago, and the general medical history only included an arterial hypertension which was treated with oral medication. So on the first examination, we couldn't find any light perception on the left eye. The slit lamp examination showed some corneal endothelial deposits, a rubeosis iridis, and some dense vitreous opacification. As you can see on the fundus photography, there was only seen a mild red reflex. So we also did an additional ultrasound, which showed a hyperreflective membrane, which was either seen as an old retinal detachment or a posterior vitreous detachment. We set the indication for an immediate vitrectomy and performed a 23-gauge vitrectomy under general anesthesia. Intraoperatively, we found some cord-like pre-retinal thickenings and extensive retinal necrosis, and in the inferior area, an old retinal detachment. In the video, you can see the intraoperative findings, and we then did an endolaser coagulation, a retinal biopsy, and some final silicone oil filling. Unfortunately, there was no vitreous body sample taken. Well, due to the picture that you can see in the video, we set the clinical diagnosis of an hepatic retinal necrosis. The patient was then post-operatively treated according to the clinical picture of the hepatic retinal necrosis with IV acyclovir with 10 milligrams per kilogram 3 times daily, some oral steroids, some local steroids injected on the orbital floor, and then some local eye drops with prednisolone acetate, some atropine, and a few eye drops to lower the intraocular pressure. On the clinical course, on the first post-operative day, we could see a pre-lentil fibrin plaque, and there were 3+ anterior chamber cells. The flare was 2+, and the fundus visualization was still very reduced, but it was possible to see the necrotic areas. We did an additional anterior chamber tap because of the missing vitreous body sample for a virus PCR that came back with a negative result. The routine uveitis workup also came back with unremarkable findings. The clinical eye situation was very stable with a moderate improvement. On the 5th postoperative day, the patient expressed a headache, which she previously denied, and also told us about a subjective feeling of confusion. So we initiated a neurological examination, an EEG, and a MRI to rule out the possibility of an herpetic encephalitis. The neurological exam and the EEG came back without any evidence for an herpetic encephalitis, but the CMRI showed some multifocal asymmetrical diffusion disturbed areas on both hemispheres, which was then seen as the clinical suspicion for an herpes encephalitis by the radiologist and the neurologist. So we transferred the patient to the neurology department. These are the CMRI pictures that were taken that day. So the colleagues in the neurology department took a cerebrospinal fluid puncture and did a PCR out of that. They didn't see any evidence for the herpes virus, and they didn't find any evidence of malignancy. The results of the retinal biopsy came back as well. The PCR showed no evidence for herpes, and the molecular pathological examination had no evidence for vitreoretinal lymphoma. So the neurology department then had the two possible diagnoses of a posterior reversible encephalopathy syndrome or a malignant cause. A follow-up CMRI was done 10 days post-operatively, and that could rule out the possibility of a posterior reversible encephalopathy syndrome, which made cerebral lymphoma a lot more suspicious. We then ordered a MIT88 analysis of the retinal biopsy and also a re-evaluation. We saw the patient again 2 weeks after the initial contact. This is a picture of the left eye. We could see a few new hemorrhages, but altogether the eye was pretty stable. The patient was then transferred to the neurosurgeons, where they took a cerebral biopsy, which then confirmed a B-cell lymphoma. The MIT88 analysis of the retinal biopsy came back with the evidence of a deleting MIT88 mutation, and the re-evaluation showed some larger B-cell lymphocytes in small groups. The combination of those two was then seen as highly suspicious for vitreoretinal lymphoma. The patient was transferred, and then a chemotherapy was started, and unfortunately, she died a few weeks after starting the treatment.
Thank you for presenting that case. So just for the panel, do you understand that we are still a little bit confused about what we've seen? So the clinical picture or what we found, this is for us, it's always normal. So you got a patient and you can't see anything on the posterior pole, and so you have to go for immediate vitrectomy. And with that clinical picture, so we separate. So we have vitreoretinal surgeons. These are not uveitis specialists, but usually the uveitis specialists go in there and look live what they see. And seeing that picture, our clinical suspicion was this is a massive, acute, long-standing retinal necrosis. And so we started with the therapy, as Charlotte mentioned, but what we can see on the long hand, so by chance, the surgeon did a retinal biopsy, but we have to insist and we ask for re-evaluation of the retinal biopsy. Would anybody have done something different, or is it both?
Carsten, this is a very difficult case, and obviously an old patient, old lady, and unfortunately she died at the end of the course. But was the vitreous analyzed by itself, cytology, IL-10, and
yes?
How was IL-10 and how was the virological analysis?
Yeah, So we have some pathologists doing a great job, and we usually can rely what they say. They don't do IL-10, so they do a normal cytology and then do all the immunochemistry findings. And usually, if they say they mention that they see some B cells, but not something suspicious for, but they don't do IL-10, so they, I can't answer that one. What the failure was probably that. So I also got some slide, but it's well known that if you do a PCR, it's working pretty good in the beginning of the infection, and later on, Goldman-Whitmer is working better, which nearly no one has the chance to do so because it's difficult to have it certified, and therefore maybe we have in this case, I guess we have got both the lymphoma, which was proven later on, but additionally, and this is also the thing that these patients who are immunocompromised are more suspicious for infectious uveitis.
Yeah, I think you are right, but this is more for anterior herpetic uveitis when you have first PCR and then Goldman-Whitmer. In the acute retinal necrosis, if you have retinal necrosis, active retinal necrosis with viral replication, you will have the PCR positive. I think it's very difficult to miss it. So that's a very complicated case. Again, nobody knows exactly what happened at the end, but I think it's probably a mixture of both.
I think it's yes, a difficult case, and I believe you made the final diagnosis correctly. During the surgical view, the image was, to me, suspicious for masquerade syndrome. It really looked like PVRL that sometimes looks like acute retinal necrosis. Of course, you can never be sure, and doing the vitreous biopsy, but going after tissue and getting a retina sample was the thing to do. I believe you did that. What I was surprised is that you could not, the pathologist could not make the diagnosis with that retinal tissue, because that usually is the case. That usually is enough, unless the sample was too small, I don't know. But if you get a good tissue from the retina, you should be able to make the diagnosis with retina tissue.
Yeah, what was the additional thing which was disturbing a little bit was when you got the MRI scan, which was primarily also by neurologists and also by the MRI specialist diagnosed as herpes encephalitis. And this is something, even if you have started treatment immediately, so we have a postponement of treatment start of around about 6 weeks in this case, there's always the risk of the herpes encephalitis. And this was another challenging thing in this case. So in the end, it was related to the lymphoma itself.
It was CNS lymphoma. Yeah.
Yeah.
Very challenging.
It's a
Probably
very
the diagnosis of the herpetic retinitis biased them. So we have to stay aware,
Sure.
like what you did. Yeah.
But they also complain if you don't write anything on it.
That's right. Yeah. So we just have to be careful about that. I mean, that's what I thought it was at that point in the presentation.
So Vishali,
Yeah, it's indeed a very challenging case. And in retrospect, we all become very wise. But when you are dealing with the patient, honestly, it's very difficult to see what is happening. And I totally agree with you. If you're suspecting on, you have to treat for on. And like Bahram said, could it be mixture? We do not know. But I think you did the best. You did not waste time because this is how everybody would do.
yeah, especially with all the things we've heard, the only way to prevent detachment, which is the most serious complication, you have to start aggressively. This is the most important point, and therefore we need to do that. And later on, we had to learn that we were wrong.
But even if you have a negative biopsy, and you have MIT88 positive with
Yeah.
IL-6 ratio, you would still take it as lymphoma, wouldn't you?
Yes, so that would yes, we do, and that was as said, it was confirmed by CNS biopsy itself. But nevertheless, you always should be able to convince an oncologist to start treatment with MIT88
That is
positive.
the most difficult part. That's very difficult, and we face the challenges every day. They do not want to start systemic treatment based on these two parameters. They need the cytology for systemic chemo. So Bahram
Yes.
have recommended a CNS biopsy earlier. Like if we have such a situation where retinal biopsy is negative, which can be negative per se in lymphoma, especially the retina. So would you recommend an early CNS biopsy based on your suspicion?
Usually the neurosurgeons or the neurologists refer to us the patients in order to perform the vitrectomy and not going for the cerebral biopsy because it's much more invasive. But in this case, it's the other way. So I would say yes, if we don't have any other clue and the vitreous was not significant for lymphoma, then you have no choice. You have to confirm the diagnosis and go for another place you can biopsy, and this was the brain. However, I would say that if you do interleukin 10, if this is something, it depends on the places, but it gives you another piece of information.
You know, I convinced my neurologist to take CSF TAP and do IL-6/10. So many times even IL-10 is elevated in the CSF. So it's, a
The
step that
problem, Vishali, is that is much less positive in the CSF than in the ocular fluids. So sometimes they are disappointed because they say we do, but it's not positive.
So the other
Bahram, their patient had CNS lesion. Maybe it would
Absolutely. Absolutely.
So the other opportunity could have been to repeat the vitrectomy, remove the silicon oil and do another retinal biopsy in another area, because there are many studies showing that one vitrectomy does not offer the right result in many cases. And the eye, anyway, that eye is a lost eye, so there's no visual acuity. Anyway, so this was a little bit away from acute retinal necrosis, but the challenge was to present a complicated case.
Differential.
Very nice.
I think you did well with the case. It's just it was bad disease. Yeah. I was going to just make one other unrelated comment before it was commented on from the Wilmer case about there was like a bubble of the phoscarnate. And we learned in the CMV retinitis days that will still be effective in the presence of silicon oil, at least in most cases. So just as a point, people can still give intravitreous treatment if there's silicon oil.
Yes, they ask me all the time if you can inject antivirals or if you can inject antibiotics, or you can inject methotrexate in the silicon oil bubble, anti-VEGF. And yes, you can. I mean, it's not a problem at all. It works perfectly. There is a meniscus of fluid between the silicon oil and the retina, and it will diffuse and it will work. I have no issues injecting in the silicon oil bubble.
Are you not afraid of any toxicity problems, because you must have a much more higher concentration?
No, because you have the still a good meniscus of fluid. I would be afraid about toxicity of antibiotics. Yes, if antibiotics are being injected in a silicon oil bubble, then I cut the concentration in half. But for methotrexate or antivirals, I keep the same dose, for example. Yeah. That's a good comment, John.
Alejandra, would you like to ask any questions, Megan, for the panel?
No, thank you.
There's a question in the Q&A about a case. I guess this is following up one of the questions I had answered about CMV retinitis, where I was saying that sometimes with opportunistic infections, we wait to treat with heart in an HIV/AIDS patient to lower the risk of getting an immune recovery inflammatory syndrome. And I was saying we shouldn't do that with CMV retinitis because based on our data from the 90s and before, the risk of death is really very high in the CMV retinitis patients. I think we had something like 20% dead before by 2 months before the heart was available. And so this question then was saying the patient had been on heart for 6 months already, and intravitreous ganciclovir was administered, but then she ended up with second eye retinitis and then put on oral valve ganciclovir. CD4 count was still 12 and then had severe thrombocytopenia. So how to proceed? And I guess I would think, local therapy would be attractive in that option, in that situation, which might need to be done, pretty open-ended unless the heart regimen can be improved and the CD4 count raised.
Bahram?
So we used to see a lot of problems like that before the antiretroviral therapy got good.
So for the sake of all the attendees who are from different part of the world, I will quickly ask a couple of questions to all the panelists. In countries like ours, foscarnet is not available. So we do not use intravitreal as a routine for acute retinal necrosis. Now, in such a scenario, would you prefer oral val acyclovir or IV acyclovir when you are giving only systemic, no intravitreal?
I don't know who will start, but in my part, I would say that I would prefer IV, at least at the beginning. If you go to oral, and I think it was mentioned by Dr. Heng and Fernando, you can increase the dosage if the kidney allows you, the renal function allows you. But it seems that if you double the dosage of oral valganciclovir, or even some people triple the dosage, you can achieve the IV pharmacokinetics of acyclovir. So I would do it like this by increasing the dosage if I can. If not, I always prefer to go for a more aggressive antiviral.
So considering the expenses involved, val acyclovir is more expensive than IV. So I still give IV to my patients. So I think the general message is that despite the Western studies, if your patient, you can hospitalize and give IV, I find it very easy because we can monitor and we can add local therapy like we have ganciclovir, foscarnet.
Vishali, foscarnet has not really proven its efficacy over ganciclovir as intravitreal injection. So if you have IV intravitreal ganciclovir, it's still okay to me.
Now, the second question would be, Sophia and Fernando, would you add intravitreal ganciclovir right from first day, or would you first start systemic and then wait for the deterioration to start?
Start on systemic first. Okay, so Fernando, go ahead and.
No, Sophia, please.
Thank you.
Ladies first.
Thank you. So I would start on systemic first, and I would close monitor. I agree with the previous comment that I like to use intravenous therapy. And I would start with systemic therapy, and then we'd see how it goes. And I don't give ganciclovir in all cases. It depends.
And Fernando, do you do PCR for all your cases to make the diagnosis, or it's just the clinical?
We make, yes, we get PCR for academic purposes. We want to know if it is VCV or herpes simplex. Want to make sure. The dosages are different in my mind. If it is VCV or herpes simplex, the dosages are higher for VCV. So I would like to know. And I agree with the starting with IV therapy if we can, and then we turn to oral. And I do add intravitreal foscarnet twice a week from the beginning. Dr. Heng showed data that shows that it decreases the chances of retinal detachment. So I think that it should be added if we can. Yeah.
Alejandra, Carsten presented a beautiful case where, like, despite of having so much experience, we all were not sure whether it was on lymphoma. Do you see diffuse toxo presenting where you can confuse it with on? And in such a case, what would be your approach to the patient?
Yes, I have a case with diffuse toxo in a patient with lymphoma, and we should treat with systemic and also intravitreal clindamycin and systemic pyrimethamine sulfadiazine or trimethoprim sulfamethoxazole plus intravitreal treatment.
And Carsten, do you add aspirin as a routine in your patient? And what is your protocol for starting and stop steroids and on?
So just to comment what Alexandra means. So very rare, I can remember one case in an compromised patient, where we first thought it was iron, but it ends up in toxoplasmosis. So you can be quite confused in immune-compromised patients. So what are our normal ways? So we also start with IV therapy, and we also start and add the intravitreal as additionally. And when we see first improvement, so that we feel that the lesions a little bit getting a little bit sharper, we started with steroids. This is depending on where we use it as orbital floor with dexamethasone, or we give 0.5 milligram per kilogram body weight oral prednisolone. But usually this is up to 3 to 5 days after initiating the antiviral therapy. Yeah. So aspirin is always discussed, and I don't know any evidence if it's working or not. But from the rationale is that you have these occlusive vasculitis, and therefore it may help. So we do it in some cases. And the difficult question I probably can't answer when to stop. So we usually stop when we feel that the acute phase of the inflammation is over, and then we taper the steroids and then we stop it. But this is very carefully done, and we never stop it. Nobody does before. So the antiviral is continued for a long time. Just the important thing is, so if I'm right with the figures, so the first 4 to 6 months are important for the retinal detachment, also in the uncomplicated cases. And if you induce more wound healing, you have this contraction, and then you got the tears, and then you got the problems. And so you must do this also very carefully to avoid a rapid change.
Vishali, to your point about acute retinal necrosis looking like toxo, I think that's an important question, because we all have seen it and have been surprised of cases that end up being toxo. It's very atypical, and Alejandra is an expert, and she responded perfectly. But that's another reason to get PCR, and we get PCR not only to rule out varicella zoster or simplex or CMV, but we get toxo PCR we want to make sure we don't miss it because it happens. Yeah.
Yeah,
So
absolutely agree. And this is important to make, as Barak talk about it, multiplex PCR
Mhm.
to cover
that
all
means
the kind of microorganisms.
But
Vishal,
unfortunately, 60% of our attendees in this webinar are comprehensive ophthalmologists from sub-Saharan and other regions. So we have to give them practical tips on how to diagnose rather than PCR. I know is ideal, but webinars are mainly for education.
Vishali,
So
I
Bara, when
for
confused,
just
would you
just
start
just
the treatments?
no, sorry, I didn't want to comment on the PCR or not. I think if you can do it, it's better. But if you cannot, of course, you can rely on the clinics, and there are some clinical signs. But what I'm impressed today, and I'm very delighted to see this, is that all the panel was for a systemic therapy, and especially IV systemic therapy in these patients. So again, I think that we have seen beautiful cases. I think that the risk of retinal detachment is important. And at the end of the day, unfortunately, many of our patients, even if the even if the necrosis is at the periphery, they will lose sight because of the optic nerve involvement, the vascular involvement, which is very important. So the most aggressive we will be, I think the best, the outcome may be, depending if we use corticosteroids or not. When we use it, it's still very controversial. But we have a lot to do, a lot of work to do on this entity, because even if we treat well our patients, unfortunately, at the end, the result is very poor.
Right. But the
I-
treatment has been initiated to protect the opposite eye. So that's the
Also,
message.
Yeah.
that's true. That's true.
Very important.
That's true. That's
I
true.
think that's more successful. Yeah.
Yeah, and how often do you monitor a patient's blood counts and kidney and liver function test on prophylactic therapy?
Go ahead.
I think
Yeah.
it depends on the patient, Alejandra, but usually if the patient has no complications, and as you are lowering the dosage of valacyclovir, I start every 2 weeks, and then I go every month or every
6
2
weeks.
months. So it's not so frequent.
So you often see something in the beginning when we start with the IV therapy. So you usually have the opportunity to monitor them closely because they're in the hospital, and then you got the first information also for the continuation of the oral therapy.
Yeah.
So over to
I was
John.
going to comment on the developing world. You know, it's sort of like practice was in more developed places in the 1990s, where we have to rely on the clinical signs, you know, which are quite good for this condition. And then we usually could figure out a way to give intravenous therapy. And so, as was mentioned before, that's, you know, not just potentially less expensive, but also more available in places where we don't have valacyclovir. And so, anyway, I in the West, I like valacyclovir because it's convenient, but the you know, worldwide, the intravenous, you know, is probably the best option.
Another problem with oral is many times because of financial constraint, patients do start the treatment, but they stop in between.
True.
So when you are giving them intravenous, at least you are ensuring compliance
Absolutely.
for the first 2 weeks.
True.
So Megan, I would like to invite you to conclude and invite for the next one, whatever the dates are. You're muted. Muted, Megan, you have to unmute.
Oh, okay. Sorry. It's really low on my computer today. I'm sorry. Can you hear me better now?
Yeah.
Okay,
Yes,
I'll speak
good.
up. I'm sorry. You told me this before and I forgot. Thank you everyone for joining today. It was a wonderful discussion. We really appreciate everyone joining at different times of the day and making time for us. The grand rounds are only a success because of you, and we would love to invite you to our next grand rounds, which will be on January the 11th, and we're going to be covering the ever increasingly interesting and evolving topic of COVID-19 and inflammation in the eye. We really hope that you can make it. And on behalf of all of the organizers and all the panelists, thank you for joining.
Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone. Thank
Bye.
you, guys.
Bye-bye.
Season's
you.
greeting.
Happy
Christmas.
holidays.
Bye-bye.
Yes, happy holidays. Bye-bye.
Bye.
Thank you. Thank you very much.
Fantastic session. Yeah.
Thanks.